Good afternoon, and thank you for joining our webinar today. We know that your time is very valuable, and we appreciate that you've chosen to share some of it with us. Before we get started with our topic today, and before we introduce our speaker, we'd like to take care of a little bit of housekeeping. We will spend a few minutes answering questions at the end of the presentation. Please type your questions in the Q&A box located at the bottom middle of your screen so that your questions can be answered at the end of the presentation. For those of you interested or in need of continuing education hours, this webinar offers a free 1-hour CEU credit through the University of South Alabama Office of Continuing Medical Education, to which you may obtain after completing the survey that will be emailed to all in attendance. For those not in need of CEU credits, we ask that you also complete the survey, as all feedback is much appreciated and helpful when planning future webinars. At this time, I'd like to share a little information with you about GPT. Global Partnership for Telehealth is a nonprofit telehealth organization with a focus on consultative services, turnkey hardware solutions, and our easy-to-use telehealth platform, Pathways. Our organization was founded in 2004 to build a telehealth network in the state of Georgia that quickly evolved into our current mission to leverage telehealth technology for the benefit of all. Our mission is to enable healthcare everywhere with the solutions we offer and our values of integrity, expertise, passion, and innovation. Be sure to follow Global Partnership for Telehealth on Twitter, Facebook, and LinkedIn to stay up to date on our webinar series, as well as other important information as we continue to leverage telehealth across the globe. Okay, it is now my distinct honor to introduce our speaker for today, Dr. Stephen Fein. Dr. Fein is the medical director of Hemi-On-Call. He has a deep-seated passion for helping people with blood disorders, including clotting, bleeding, abnormal blood counts, and blood cancers. Dr. Fein trained at Johns Hopkins School of Medicine, Duke University, and the University of Miami. After dedicating himself to hospital-based hematology and oncology for 15 years, he created Hemi-On-Call to provide access to care by telemedicine for inpatients admitted to hospitals that have little or no hematology or oncology support, and for outpatients who have limited access to or who prefer to see a hematologist from the comfort and convenience of their home. Those of you who have joined us in the past know that Dr. Fein has presented 2 previous webinars on hematology. Each of those webinars have been recorded and can be found on our website at gpth.org. Dr. Fein, we appreciate you being with us here today, and I'm going to turn it over to you at this point. Just as a reminder, if you have any questions, there is a Q&A button at the bottom of your panel. We will review those questions, and Dr. Fein will answer those live on air as soon as his presentation is concluded. Thank you, Dr. Fein.
Thanks so much, Jennifer. It's a pleasure to be back for the 3rd time. Thank you for inviting me to give a short but interesting and informative presentation for the GPT network. And anybody who's interested in listening to a hematology topic, I promise this will be worth your time. I'm going to review sickle cell disease, a topic that all of us need to be aware of and stay abreast about. Unfortunately, I don't have so much of an update because there's not much news. It trickles in little by little, updates and important innovations in sickle cell disease. But all of us need to stay aware and informed about what's happening in general with sickle cell disease. I'm going to focus on sickle cell disease, and then I'll be discussing sickle cell trait, which is important. It's important to realize it's a separate entity, even though they sound similar and they're similar genetic mutation concept, they're different entities. And lastly, I'll be talking about telemedicine for sickle cell disease and sickle cell trait. Now, I have already a year and a half of experience with my partnership with GPT, and it's a pleasure to be part of this network and to be able to discuss these topics, and also to be working towards developing telemedicine for Florida and Georgia and all over the country for hematology. So the three foci for the next few minutes, we're going to talk about sickle cell disease in general. We'll talk about what it means to have sickle cell trait, and then I'll be reviewing how telemedicine hematology is changing the care for sickle cell patients and sickle cell trait patients. So First, I want to remind everybody that sickle cell disease already has 70 or so years of understanding of the pathophysiology. A single point mutation, a single base pair point mutation, is known to result in polymerization and clumping of hemoglobin on the left side, which results on the top right in sickling of the red blood cells, the sickle shape of the red blood cells, and just misshapen red blood cells that ultimately lead to a whole array of challenges and problems and a shorter lifespan for patients who have this single base pair point mutation. On the bottom right, you see an example of the blood smear in the microscope showing the sickle-shaped cells admixed amongst regular shaped red blood cells. Now, there's a rich history of what was once called sickle cell anemia, but clearly ought to be called sickle cell disease. Sickle cell anemia is historically one of the original and probably the very first genetic disease, a disease in which a single base pair point mutation is known to have pathophysiology that leads to such a broad array of challenging problems in a shorter lifespan. And this was a disease that was understood as a genetic and hereditary disease long before we understood so much about DNA. Famously, Linus Pauling is credited partly for describing and discovering sickle cell disease. You probably know that he won the Nobel Prize, but not for this work. His work in chemistry resulted in a Nobel Prize, and he also won the Nobel Peace Prize, making him one of the rare folks who have won 2 Nobel Prizes. Now, sickle cell disease is known to have its origins in Asia and Africa, and this shows you an example of the concept that there are at least 4 original sickle cell mutations, which each have different patterns of manifestation. And the common thread amongst these genetic origins is that these are genetic origins that are felt to or appreciated to have resulted in protection against malaria. Now, malaria being a tropical disease, well known to be prevalent in African countries, no surprise that would possibly have provided selection advantage for folks who had a heterozygous mutation and were protected against malaria. And we don't really understand much more than that about how it would have resulted in problems for people who were homozygous back in these eras. But we know that its origins are like that. In the United States, in 2021, there are at least 100,000 people living with sickle cell disease. And this therefore affects 1 in 500 African American people. And also, it's on the bottom, you see that there's a prevalence of sickle cell mutation, sickle cell disease amongst Hispanics. And it's less common than African Americans, but still common enough to be a problem and to be something to be well aware of and to screen for. Importantly, sickle cell disease and sickle cell anemia resulted in an extremely short lifespan until about 40 years ago. So you can see the red line shows that people died in childhood of sickle cell disease, most commonly of infections. That was the average life expectancy was in the teens. So you can't even believe this kind of disease could occur. Now, starting in the 1970s, with better understanding, appreciation, awareness, and management, and ultimately, importantly, the use of antibiotics as a prevention and just effective treatment with antibiotics resulted in the average life expectancy being in the 30s. And you may applaud that, but incredibly, that's not very different from where we are today in the year 2021, where the average life expectancy is probably still in the 30s or 40s. And you have some people living longer with it, but unbelievably, people do not live so long with sickle cell disease. We do not have a cure for it, with the rare exception of some people getting bone marrow transplant. Otherwise, almost nobody getting cured. We're on the cusp of doing gene therapy, but not there yet. And finally, we've got some better treatments that help people's quality of life, but not so much their lifespan. The past 50 years then have seen, importantly, better use of antibiotics, use of pneumococcus vaccine, and aggressive inpatient treatment for sickle cell disease infections. Also, the modern era has seen better understanding of and use of tools to prevent stroke, and, for example, having monthly blood transfusions as a concept to prevent stroke. So this is how it became survivable as a youth. And as an adult, we still have challenges helping people with sickle cell disease survive long. To decide who needs to be tested for sickle cell to make a diagnosis, it starts with having anemia, commonly African American or Hispanic American people. It doesn't have to be, it can be other ethnicities, and you sometimes don't know people's ethnicity just by looking at them. So you have anemia in the right person. You sometimes see low MCV in the blood smear, but not always. In fact, not commonly, but sometimes. In the cases where someone has low MCV, it's commonly a combination of sickle cell trait with alpha thalassemia. So just to tell you, the MCV doesn't usually help. Importantly, when you have hemolytic anemia, like sickle cell disease, you have high retic count and high LDH, and that would be the hallmark of sickle cell disease. That would be a diagnostic test. It's commonly misconstrued as a test to see how severe somebody's sickle cell disease is, and it really ought not be thought of that way. If anything, it's just a diagnostic test. Somebody with hemolytic anemia could have sickle cell disease, and the most important diagnostic test is the hemoglobin electrophoresis test, which displays on a gel, on an electrophoresis gel, the actual sickle cell hemoglobin in its size and shape that can be interpreted as a sickle cell hemoglobin S hemoglobin. Now, sickle cell disease comes in different variants, and what we're focused on for the most part today is the term sickle cell anemia, or sickle cell SS on the top, where the hemoglobin is low, and commonly as low as 6. People live with this hemoglobin, and this is hemolytic anemia, so they're producing plenty of blood, but the hemoglobin stays in the 6 to 10 range. I want to call to your attention that other sickle cell variants include sickle cell, you could call it trait combined with beta thalassemia, which would result in not just hemolytic anemia, but also a production problem where you can't produce that much hemoglobin. And in these cases, depending on the severity of the beta thalassemia phenotype, the hemoglobin can be even lower than 6 to 10, but still most people are in the 6 to 10 range. When you do the hemoglobin electrophoresis, you'll see that there is some hemoglobin A, which is called the normal hemoglobin, but the S is much greater than the A, commonly something like 20% A and 80% S. The third line says there's such a thing as hemoglobin S with alpha thalassemia trait. And in these cases, the hemoglobin A will be much more than the S, so it kind of looks like a trait patient. In this case, the hemoglobin S will be 20%, the hemoglobin A will be 80%. The fourth line shows the entity called hemoglobin SC, or sickle SC. These are patients who do get sickle crises, but their hemoglobins stay higher, and the hemoglobin will be 8 to 11 range. And finally, there's hemoglobin SS combined with hemoglobin F. We call it persistence of hemoglobin F. These are patients who commonly have their hemoglobin higher, partly because the F isn't as serious a problem for hemolysis and maybe protects them, we think. And these are commonly people who have a better quality of life and possibly more longevity. Now, in general, the way sickle cell disease manifests is all these things we're going to discuss in some detail. These are hemolytic anemia on the left side, and then vascular occlusion, vaso-occlusion on the right side. And it's kind of a spectrum in the sense that people who have more hemolytic anemia don't necessarily have more clotting. So the clotting is sometimes not in the most severe hemolysis patients. It's kind of a spectrum where you can see on the bottom that patients who have more hemolytic anemia wind up with other problems, including pulmonary hypertension, leg ulceration, and then some rare sickle problems, including priapism and stroke. Whereas on the right side, the patients who are kind of more vascular occlusion, not necessarily focused on clotting, but vascular occlusion, these are patients who have more pain and more chest crises, acute chest syndrome, and more bone problems. They're not necessarily the ones that have the most significant hemolytic anemia. On the left, I do make the point on the left that stroke and priapism, things that are considered vascular problems as well, occur more commonly in people who have more hemolysis. So this is all generalities, and every patient with sickle cell is different from the next, but just to show that there's a spectrum of disease ranging from more hemolytic anemia and more pain. The four most important challenges that most sickle cell patients face in one way or another is the risk of infection with their immunocompromised state, the risk of clotting, or we'll say microthrombosis, resulting in essentially every organ being injured and damaged, the risk of bone pain, including the concept of vaso-occlusive pain crisis affecting the bones, and finally, chronic hemolytic anemia. As I say, there's kind of a spectrum of chronic hemolytic anemia versus bone pain, but people commonly have both. I'll first talk about infections. Really, the most important advances in all of the history of sickle cell disease have been advances in providing awareness of infection risk and providing antibiotics. Even the concept of giving prophylactic daily penicillin is probably still one of the most important sickle cell disease concepts. Also, now we have vaccines for influenza and pneumococcus. Importantly, sickle cell patients have infection risk all around, including infections in the ports that they end up with, urinary tract infections, the concept of having a parvovirus infection that causes them to have what's called aplastic crisis, that therefore they can't produce red cells to make up for all their hemolytic anemia. The risk of hepatitis and other bloodborne or blood transmitted infections. And finally, osteomyelitis occurs more commonly among sickle cell patients. And weirdly, we have to learn this and pay attention to it, that sickle cell patients develop salmonella osteomyelitis, in addition to regular kinds of osteomyelitis like staphylococcus. Sickle cell disease affects every organ of the body. It affects the brain, causing stroke, meningitis, and also brain injury from ischemic damage, and possibly the concept of cognitive dysfunction. It affects the chest with the concept of acute chest syndrome. It affects the liver, going on down, the spleen, the gallbladder, bones on the bottom, priapism. Sickle cell affects every organ of the body. Just think of every organ as affected. The things that we pay a little more attention to are the concept of pulmonary hypertension, and the fact that once sickle cell patients live long enough with this concept of having abnormal blood viscosity, they commonly, if not all, get pulmonary hypertension eventually. So overall, the current prevalence of pulmonary hypertension is estimated at 10%. That's more or less just based on having people reach a certain age. Shown on the right side, once somebody has sickle cell related pulmonary hypertension, their mortality is thought to be significantly impaired, and they have significantly higher risk of dying related to heart and lung problems. To make a diagnosis, you need to do the echocardiogram, and people who live long enough with sickle cell disease, probably even just into their 30s and 40s, ought to have echocardiograms on a regular basis. In order to minimize this challenge and prevent it, we're using vasodilator drugs like sildenafil, and also the medicines used for sickle cell like hydroxyurea and blood transfusions and anticoagulants. I'll touch on sickle cell hepatopathy, a common problem amongst sickle cell patients who get into their 30s and 40s and older. Just liver dysfunction, liver impairment, intrahepatic cholestasis. There's kind of a spectrum of hepatopathy, which is both cholestasis and liver enzyme abnormalities. These are patients who get very sick. Their bilirubin can be 20, 30, 40. They get hospitalized. In addition, and separately, almost every sickle cell patient eventually gets gallstones and high risk for getting acute cholecystitis. So, and even possibly dying of acute cholecystitis if it's not solved right away. So these are liver problems associated with the sickle cell. The kidneys commonly impaired as well. Almost every patient who lives long enough, meaning 30s, 40s or older, eventually gets renal dysfunction. There's such a thing as having subtle or maybe overt renal infarcts. And then there's also subtle renal dysfunction like microalbuminuria, and then there's special sickle cell related disorders known as papillary necrosis with hematuria and medullary carcinoma, a kidney cancer related to sickle cell disease. So important things to pay attention to, and unfortunately many sickle cell patients wind up on hemodialysis as they live longer, and that becomes disabling and life-threatening. Other problems associated with sickle cell, I mentioned gallstones. It's priapism, commonly among sickle cell men. Even subtle priapism where the patient's not really talking about it, you have to ask about it. Aplastic crisis, I mentioned, associated with parvovirus B19, neurocognitive defects, and in general, malnutrition. When it comes to sickle cell patients who are hospitalized, the critical thing is to figure out who's got an infection and put them on antibiotics right away. Also beware, a sickle cell patient is associated with DVT-PE. We think of it as a microvascular problem, but there's plenty of macrovascular DVT-PE. So very important to have essentially every sickle cell patient in the hospital on anticoagulants, even if they've never had a clot. The concept of giving blood transfusions, I will go into more depth about, but you have two different kinds of transfusion. Simple transfusion to give a red cell unit from a donor, or exchange transfusion, where you're giving and removing. And you have to appreciate that we're really treating the patient here and not just the numbers. because the sickle cell numbers, when someone comes in with hemoglobin of 6 or 7, they don't look so sick, whereas a regular non-sickle cell patient who has hemoglobin of 7 or 8 and might look sick, you have to see that the numbers are all different. So you have to be aware that we're focused on treating the pain or the clotting concerns and not just the numbers. Also in the hospital, a great emphasis on pain control, including opiate medications, non-steroidal anti-inflammatory medications, and steroids sometimes. So lots of things to think about in the hospital. In general, we don't focus on hydroxyurea as a hospital-based medicine, but sometimes you have the concept of starting somebody in the hospital just to show them that this is a medication they can tolerate. I would say that in general, hydroxyurea is an outpatient medication. So how do you know when to give a sickle cell patient a red blood cell transfusion in the hospital? Well, the answer is anything serious going wrong with them. It's anybody who's got severe pain, anybody who's got acute chest syndrome, anybody who's got priapism, anybody with a stroke. Also, on the left side, you see there are special cases like the concept of aplastic crisis with parvovirus B19 infection. And then there's also the concept of a splenic sequestration crisis. This is mostly in children with sickle cell. As you realize, as you probably know, adults with sickle cell have dysfunctional spleen that doesn't have that sequestration thing. That's a childhood thing. So the idea is that you have to use your judgment about what's going on with the patient. And it isn't an automatic thing to want to give transfusions. It should not be. And it isn't directly related to the numbers. The numbers may be part of the picture of the hemoglobin, but it's more to do with what's going on with the patient. So what I'll say is that red cell transfusions are needed for patients who have refractory vaso-occlusive crises. Once you've figured out that pain control is not going to be obtained by just giving them pain meds. So you consider transfusions, and you're treating the numbers because they all have low numbers when they're having that kind of pain. But these patients are really being treated as a palliative pain treatment and not necessarily expecting to raise the hemoglobin. In fact, the best you can do is probably raise the hemoglobin a little for a short while, because ultimately they wind up with hemolysis of the transfused blood, and you're not solving the problem of their low hemoglobin. You're solving the problem of refractory pain. In the second bullet, there are some patients who won't get out of their crisis without pain, without a transfusion. So you have to know your patient and know who needs a transfusion. In the third bullet, we're commonly giving red cell transfusions for acute chest syndrome and other clotting concerns. And there's the concept of giving exchange transfusion, especially on the fourth bullet, a patient who's had an obvious stroke related to sickle cell, try for exchange transfusion. You hear about using exchange transfusion for acute chest syndrome, but I would say only the most severe cases that you're obligated to try for exchange transfusion. Other cases can get by with simple transfusion. And the last bullet, I wanted to make the point that we still have this concept that before a major surgery, even including gallbladder surgery, we like to see people's hemoglobin closer to 10. And this is an old concept that really doesn't have evidence backing it up, but there's a hint of feeling that this will decrease their chance of having a crisis after the surgery. Now, every time you give a blood transfusion, you have to weigh the benefits against the risks. So when it comes to sickle cell patients, transfusions almost always help them. So there's a lot of benefit. But just like everybody with transfusion, you have to weigh the risks against the benefits. So on the bottom, you see the short list of risks associated with blood transfusions, including the concept that anybody can have a transfusion reaction, and concerns about infections transmitted by the transfusion. And so a lot of times we focus on hepatitis transmission, and HIV transmission is very, very rare, but there are infections that we don't appreciate, including regular bacterial contamination infection. So transfusion reactions and infections should weigh on every single transfusion decision that you make. Also, over time, patients with sickle cell disease wind up having alloimmunization. And there's a lot of research on this and trying to figure out how to minimize that from occurring, decrease that chance of occurring. And some blood banks are very attuned to this. But what I'll say is that no matter the best you can do is still not so great. That over time, as you give more blood, you're decreasing the chance that they will one day benefit from blood that they need even more. And finally, on this list, iron overload. Every time you give a blood transfusion, you're giving approximately 250 milligrams of iron. So over time, patients develop iron overload and organ damage related to that. I'm going to go on to and just mention about the iron overload. Over time, people with sickle cell disease, any situation with getting excessive blood transfusions, wind up with hypothyroidism, wind up with concern for adrenal dysfunction, concern for gonadal dysfunction. And then they also have liver dysfunction, heart dysfunction related to iron overload. You see the testing for that, for looking for iron overload, is the ferritin, also looking at the heart with echocardiogram, special liver imaging. And that's a way to assess iron overload. In order to treat iron overload, anybody who's had more than about 20 lifetime units of blood transfusion can be assumed to have a concern for iron overload, particularly if it's within a short period of time. And that's something that we do see in sickle cell patients, getting quite that many or many more transfusions if they're hospitalized. You see the ferritin more than 1,000 is a warning that there's potential iron overload. When that happens, we consider iron chelating medications, which are now so easy to obtain and to get for sickle cell patients. You have IV Desferal and oral Exjade or Jade. Use caution in patients that have liver or kidney dysfunction, and just be aware that you have a window of time in somebody's life to prevent their liver or kidney dysfunction related to the iron overload, or at least the liver dysfunction. And if you wait too long and they're too impaired by this iron overload, then you'll miss their window to prevent it, protect them. So my recommendations for blood transfusion decisions are to try to plan transfusions ahead of time so that you're not giving them on the spot, to pre-medicate people getting blood transfusions to minimize their risk of transfusion reaction, and even the concept that a steroid transfusion might help prevent the transfusion reaction, maybe help prevent alloimmunization. Try to transfuse 1 unit at a time, not 2. There's no good reason that a sickle cell patient must have 2 units at a time. 2 units at a time would be for people who have bleeding, not for sickle cell crisis. Remember that the goal here is not to increase the numbers, but it's just to help people feel better, pain control, palliation, get out of the hospital. And finally, you have to weigh the benefit and risk of IV fluid. When you give IV fluid to sickle cell patients and you do hemodilution, you'll wind up deciding to give them more blood because of that. So you have to use your judgment about how much fluid you're going to give them. Sickle cell patients have chronic pain, and the chronic pain results in this chronic impaired viscosity, impaired inflammatory problem, all related to hemolysis, chronic nitric oxide release related to hemolysis. And these are patients who have chronic pain affecting their joints, their bones, and they have a hyperalgesia associated with getting a lot of opiate medications. So even chasing your tail on this, you give them opiate medications and they end up having even more pain. I would say, but although it's not something well studied or proven, that people who have more pain, more chronic pain, probably have an earlier mortality, if for no other reason the fact that they wind up hospitalized more often and having more things done to them. What is so hard about this? Why do we have such a hard time with this pain? Well, part of the problem is that we don't really understand it, why they get so much pain, and what none of us who don't have sickle cell disease can relate to the amount of pain or the type of pain that sickle cell patients endure every single day when they have chronic pain. One of the problems is that we don't really know how to define it. When someone has a pain crisis, it's all defined by the patient telling us they have pain. That's oftentimes challenging for any of us to understand how a subjective measurement can be their diagnosis. You ask them how much pain they have, and they'll sometimes say 10 out of 10, even when they don't look like they're in severe pain. So it's a challenge in many ways. Who should be in charge of this pain crisis when they're in the hospital? Should it be a hematologist? Should it be a hospitalist, a pain specialist? The patient themselves ought to be the expert, you'd think. And then we always ask them, and we always wonder, are they addicted to pain medications? We always wonder. Finally, we're puzzled by this because they stay in the hospital oftentimes for days or weeks, many patients. Now, this is not the majority of sickle cell patients. These are the ones that are sickest, or the ones that have the most challenging condition. The majority of sickle cell patients are home managing their pain and hopefully staying out of the hospital. It's very challenging to balance the physical and psychological aspects of pain management, pain control. And there's no single diagnostic test for sickle cell pain crisis. There's no diagnostic test. The LDH would take do not diagnose pain crisis. What you have to do is ask the patient how much pain they have and use your judgment about whether they have indicators of pain like tachycardia. Finally, your blood counts and the LDH don't show whether they have pain. You have to ask them. Once we decide that somebody has a pain crisis, each patient has a different trajectory for pain control. We have to customize it to what they need. Commonly, a pain crisis often lasts 2 or 3 days. I say should There's no should. It should be whatever amount of time the patient needs to get out of pain. But it's so frustrating to many of us who are hospital providers to have sickle cell patients stay in the hospital for days receiving pain medication when you perceive them not to be so ill, but they have pain. So you have to weigh your judgment about whether they are justifying this aggressive pain management just based on their subjective feeling of pain. Oftentimes we have to just go with what they're telling us. And sickle cell patients oftentimes end up getting opiate tolerant. So we can't comprehend the kinds of pain medication doses that they commonly need. So it just gets challenging to understand this, particularly for any of us who just does not have sickle cell disease and can't relate. There are guidelines in the world about how to manage sickle cell pain, and the basic concept is get on top of it. Get on top of it. Treat it aggressively, promptly. Opiate medications, morphine, Dilaudid. Get the pain control, and then reassess every few minutes for pain control and sedation. And try your best to use non-pharmacologic approaches, including warm packs and warm pads, and try to help people work it out so they don't need so much opiate medication. But the bottom line is that we commonly need to use opiate medications. At the bottom, you see this guideline recommends using PCA, patient-controlled analgesia, in the ER as soon as possible, as soon as the patient's going to be admitted. Now, don't forget to be vigilant for infections in patients hospitalized with pain control. So these are my recommendations. When somebody has refractory pain, be calm and patient about it, because the patient's just as frustrated as you are trying to control their pain, trying to get them out of the hospital. And try to be courteous to the patient, even though you're puzzled by the fact that they can have pain that lasts so long. And consider giving them red cell transfusions once they reach a point of being refractory. Consider imaging for whatever part of the body is hurting to see whether they have an obvious bone infarct. And then reassess them for risk of infection or possibility of infection. Consider using antibiotics. Use antibiotics liberally. I sometimes recommend steroid medications for pain control, but that's not something that's written as a guideline anywhere. A lot of psychological, psychosocial support, and I encourage patients to get out of bed and try to kind of work it out. This is an example of avascular necrosis of the hip joint associated with sickle bone infarction. The worry is that sickle cell patients actually die of the thing called acute chest syndrome. Acute chest syndrome is a combination of having the possibility of infection and the likelihood of having infarction, clotting, infarction, the concept of fat emboli within the lungs. The way I look at it, you kind of know it when you see it. There's no single diagnostic test, but the general idea is that any sickle cell patient who describes chest pain and has fever and has hypoxia and has a pulmonary infiltrate on an X-ray. So these are things that happen to sickle cell patients, and what commonly happens is that it's 2 to 3 days after they're admitted. So you get kind of complacent the first day. You say this is a sickle cell crisis, and you give them pain medication. And then 2 to 3 days later, they get hypoxic and they get very ill very fast. And this becomes what's kind of like a positive feedback thing where they get more clotting that just does them in. And this is how sickle cell patients die in the hospital. And they'll die 2 or 3 days after they're admitted. And you look back and you can't even believe that you saw them the first day, not that sick. So acute chest syndrome looks like pulmonary infiltrates. And you have these clots that are lipid-laden clots, fat emboli. And the management then is, once you decide that somebody has it, is to give oxygen, consider giving steroid medication, give antibiotics. You're treating everything, treating clotting, treating infection, and consider blood transfusions, consider exchange transfusions if they're very ill, particularly if they're on a ventilator. So lots of things with acute chest syndrome. Our concept to try to avoid acute chest syndrome is to provide incentive spirometers, and that's known to be beneficial. Now, hydroxyurea is a medication already for 30 years known to minimize sickling and to increase hemoglobin F. And the concept is that, or I should say, it minimizes sickle-related vascular injury. The concept is that hydroxyurea is a beneficial treatment for sickle cell patients to prevent crises and maybe to minimize their risk of getting in trouble with a crisis. On the right side, you see two different versions of patients doing better on hydroxyurea. This is something so challenging for all of our sickle cell patients to get into because they don't feel better on hydroxyurea. They just have fewer events. So it's not like you're twisting their arm to take a medication that isn't going to make them feel better day to day. They may still live in chronic pain, and it's very hard to convince a lot of sickle cell patients that this is worth it. But if you show them this evidence that they'll have fewer events and possibly even live longer with this, this is something that is now a standard recommendation for almost every sickle cell patient to get onto hydroxyurea. Now, there are three total more recent medications. Hydroxyurea is 30 years old, 30. There are three other sickle cell medications. Shown in the middle, L-glutamine is a medicine nutrient that is it's an amino acid that's able to prevent vaso-occlusive episodes. The problem is that medication has to be given in very high doses, and it's being sold as a medication, pharmaceutical dosing and not just physiologic dosing. And that L-glutamine is beneficial for preventing crises, although I don't think we've seen a great deal of support on that. On the top, you have an infusion medication every 2 weeks at first to prevent crises. It was approved a few years ago, crizanlizumab, and that's a medication that we should be encouraging our sickle cell patients to seek. And finally, on the bottom, voxelotor was approved a couple of years ago, and that's a medication, an oral medication known to decrease hemolysis and increase hemoglobin levels in sickle cell patients. So these are medications that are available, and as I say, there's not a lot of update. This is basically it in terms of what's new in sickle cell disease, but everyone needs to be aware of all the old stuff. There's a lot of what we call sickle cell maintenance, including vaccines. Really, vaccines would be the top priority for prolonging people's lives. Also, hepatitis vaccine, hepatitis B vaccine, and hepatitis C identification and treatment. And then there's just nutrition concerns, blood pressure control, evaluation of proteinuria, and getting everybody onto Hydrea and eye exams. Lots of things for sickle cell providers to do. I'm going to discuss for a few moments what it means to have sickle cell trait, and just to make sure that everyone understands that it is a very different entity, even though they both sound the same and they're both the same actual point mutation. Sickle cell trait is a different entity. Why is it so important? Well, first of all, sickle cell trait is identified by that same hemoglobin electrophoresis test. And this is a test that you ought to be doing for people that don't even have anemia. So if you're worried about sickle cell disease, you do that test thinking that you might find sickle cell disease. But if you're looking for who has sickle cell trait, you have to have your eyes open. And more or less, you have to test everybody who's African American who's not been tested before. It should just be a broad net. And in fact, there's a lot of talk of screening every pregnant woman who's African American, and even some who say that we should screen every pregnant woman, period, and then ultimately screen many children. And the concept is that sickle cell trait is important to know about. It's so common. On the bottom, you see it's estimated that 4% of the world's population has sickle cell trait, focused mostly on African and Asian groups where it's more prevalent. But there's plenty of sickle cell trait in the United States. People with sickle cell trait usually have a normal lifespan, and they usually don't even need to think about this. But it comes up oftentimes because they can get sick, and there's even such a thing as having sudden cardiac death. So you can feel great and have a normal quality of life, and then you get very sick from it. So this is something that now in the era where people understand their genetic makeup, this is something that people should know about themselves. And that's the test. It's just literally a blood test. Now, historically, sickle cell trait was thought to be just the way to transmit sickle cell, to be you're a carrier. And so if you're a person who has sickle cell trait and you marry somebody with sickle cell trait, then you have a 25% chance of having offspring with sickle cell disease. This is regular genetics. And this is something that still is being taught and thought about. People are learning about sickle cell disease, that this is just a carrier state. But we know it's much more than that. It's very important that everyone understand the sickle cell trait is not completely harmless. Here's an example of a paper that describes the spectrum of problems that people get with sickle cell trait. On the bottom left, very commonly, they get chronic kidney injury, chronic kidney disease, proteinuria, clotting, DVT-PE, and then there's also this entity of renal medullary carcinoma, actually kidney cancer associated with sickle cell trait. Now, in the middle and the bottom, there's an entity that's rhabdomyolysis related to significant exertion. There's hematuria and the entity called renal papillary necrosis. And then very commonly, but a weaker association on the bottom, is the concept of sudden death. I should say less common, but importantly, is the concept of sudden death related to sickle cell trait. Splenic infarction is common, relatively common. There's the possibility of getting acute chest syndrome even without having sickle cell disease, patients who have sickle cell trait, and pregnancy complications, including miscarriage. So a lot of stuff here to think about for sickle cell trait. Back 15 years ago, there was a look back at young athletes who were college athletes who died of sudden cardiac death, and known to this list on the left, known to have had sickle cell trait identified after they were found to have died. A big push in about 2010, about 11 years ago, for screening all NCAA college athletes to find out their sickle cell carrier status. And in fact, the NCAA's policy is that all Division I and now also Division II and III student athletes are recommended to have sickle cell testing and to show the results of the test, or to sign a permission that they're not going to do the test. A big push back about 10 years ago started to identify sickle cell trait amongst athletes, just because these are the ones who are known to get into trouble and have a risk for getting into sudden cardiac death. Now, I'm going to discuss in my last 5 minutes the concept of using telemedicine to manage sickle cell disease and to help people understand sickle cell trait. This is what I've been doing. I started telemedicine practice. I recognize that outpatient hematology is very challenging on all fronts. Outpatient hematology, we have hem-onc providers who really don't love hematology. We have hematology patients who are being told to go to oncology offices that can't wait or don't want to wait for an oncologist to see them. And in general, these are conditions where you can have a lot of conversation about the blood test results. So you really don't have to have an in-person physical exam for almost anything related to hematology. Now, shown on the bottom, we're commonly doing this, hematology providers are commonly doing like curbside and email consults. So, for example, I'm commonly asked about clotting related to COVID infection and COVID vaccines. So I decided that this is something that we shouldn't just do on the phone as a by the way situation. We started a telemedicine practice. So my group we started the first nationwide outpatient telemedicine hematology practice. We enable patients to see a specialist focusing on non-malignant hematology online within a day of requesting the consult. We see people who need an urgent evaluation. We can do the lab testing either by sending people to a lab near where they live, or to another doctor's office. And we've shifted the priority of hematology away from in-person exams toward education about their lab tests and their blood conditions, including sickle cell disease and sickle cell trait. And when it comes to sickle cell disease, we're trying our best to keep people out of the hospital. So I started this practice a year and a half ago, started writing about it. We take care of women's health hematology, including heavy menstrual bleeding and iron deficiency and pregnancy-related hematology. And we take care of all these other hematology concerns, including people with iron deficiency from bariatric surgery, clotting patients with DVT-PE. We help advise them about their anticoagulants. We help people with bleeding disorders, bleeding tendency, hemophilia, ITP. On this list in yellow, you see we are focused on helping sickle cell management, both sickle cell disease and sickle cell trait counseling. What's different about televisits versus in-person visits? Well, of course, you have televisits where you can have access to care anywhere, anytime. We can make it quick and easy and efficient. And there's, of course, no infection risk of transmitting COVID amongst telemedicine provider and patient and other providers. However, just like you've understood, I'm sure, telemedicine has its limitations. For decades, people worried about what would it mean to not have an in-person physical exam. I'll make the case that there is an in-person there's a telemedicine physical exam that's nearly as good, that you see someone on the screen and you get a sense for how they're breathing and how comfortable they are or uncomfortable, and whether or not they're coherent and able to have a conversation with you online, and whether they're able to stand and sit and walk if you want to ask them to. And so we do a lot of physical exam online, but there's not an in-person physical exam. I'm not using stethoscope over the web. Now, there's a lack of awareness of the vital signs. If somebody's hypotensive, then I won't know it. That's a recognized issue here. And I just have to understand the limits of telemedicine. When somebody looks ill, I have to tell them to go to the hospital and not stick with the televisit. And finally, I think most importantly, the limitations of televisits are there's a lack of in-person human interaction, and people would like to have you hold their hand and hug them if you're given bad news. I think right now in the COVID era, we can do without that. But once we get past this, we're going to miss that for televisits. And both goes both ways. The patients need the provider to hold their hand and touch and hug them and touch them, and also the provider benefits to some extent from giving the patient a hug. All of it. So before the televisit, we can serve people in rural areas, and we do a lot of good by interfacing with the providers and doing what I consider to be rural hospital and rural outpatient telemedicine. That's what I think GPT is mostly focused on. And we are able to prepare the patient and prepare our televisit by seeing their lab testing in advance. And most importantly, I think patients find this convenient. So before the televisit, meaning they don't need to actually drag themselves to a doctor's office. They can actually just plan to see us at home. Commonly in the evenings, we're doing these televisits. During the televisit, I find that patients are less nervous in front of their phone or in front of a laptop, and they're less nervous than they are in person. There's none of this white coat anxiety, and they're able to tell you more. I find that people are talking a little better online usually, and family members who are not able to come to see the doctor, family members are sometimes able to do the televisit with the patient from their house. So you get that benefit. And also family members who are not in their house but are separated, maybe they're in a different city, are able to get on just like a Zoom call where you can have them get on at the same time. So lots of advantages to using telemedicine, televisits for hematology. And finally, after the televisit, we can do follow-up very easily. We can do frequent televisits, see them every week. We email back and forth with patients. We email, communicate their provider, their doctors, and we sometimes do weekend and evening televisits to make it easier for people. And finally, we can offer people services in their home, for example, blood draws sometimes, phlebotomy, just making it all easier and cheaper for the world, and also making it convenient for patients in certain cases. So my last comment then is how do we apply this to sickle cell patients? So far, we have been working with sickle cell disease patients, and the way I see it, we've been seeing this as an outlet for patients to discuss their discomfort, their disabling disease. We hear them, we give them empathy, we are here to be an ear for them, telling us how they're suffering. And we are aware that we're not going to solve their problems so easily online, but we counsel them about their pain and their problems and their clotting and their clot risk and their anticoagulants and their infection risk. And we try to make sure that they've got Pneumovax. And if they have pain, we try our best to provide them with pain medication. Sometimes we're able to keep people out of the hospital. We try to help people avoid extra blood transfusions. We try to get people onto sickle cell medications, try and get people onto Hydroxyurea. I think it's a lot easier to hold the hand of the sickle cell patient getting onto Hydroxyurea online than it is to have them come to an oncologist's office to discuss it. Now, when it comes to sickle trait, this is my very last point, we have to make a great effort to screen essentially every African American person for sickle cell trait. If they're not already aware of their status, they need to know, and we need to know as providers. We are women's health providers, so we're seeing a lot of pregnant women who have anemia, who have iron deficiency, and even if they don't have anemia, and we're seeing them for something different, we are more or less recommending sickle cell trait screening for every African American person, and commonly Hispanic American individuals. So we're asking them about it. We're doing the testing. It's just a blood test. And we are counseling. On the bottom, you see we are counseling them about the results, counseling people who have sickle cell trait. We have a discussion about anticoagulants. That's most of what we talk about because we know that sickle cell trait is associated with pregnancy complications like preeclampsia and also associated with clotting tendency. So we have discussion about anticoagulants, whether or not they've ever had a clot. I've discussed over the past hour or so about sickle cell disease. We talked about how it's a common problem affecting many people to suffer and to cause early mortality. We've discussed sickle cell trait as its own separate entity, even though it has the same name, same mutation, but it's a problem that is underappreciated and needs attention. And finally, I've discussed how telemedicine hematology is our solution to the challenge of taking care of sickle cell patients and identifying those with sickle cell trait. Now, what I'd like to do, thank you so much for listening. I'm going to open it up to questions, and I have a few questions already posted. I will start and just go through these questions. Thank you so much. So first of all, I have the question, what types of equipment are needed at presentation sites for hematology services? So we're dealing with a blood condition where you just need blood counts and access to lab testing, including testing for hemolysis, hemolytic anemia, LDH retic, and importantly, testing for that hemoglobin electrophoresis. So just anyone needs access to the lab services that we expect to be available to most people using telemedicine. Sickle cell disease patients also need access to other providers who might need to be in person. Like they need to have access to a nephrologist or a GI specialist or a pain medicine specialist. And some of this can be online by other providers. I'll do the hematology portion, but then sickle cell patients need access to other specialists in many cases. And also they need access to the pharmacy to actually get their hands on pain medication and other medications for sickle cell disease. So lots of services would need to be provided. Also, sickle cell patients commonly need to be able to go to a hospital if they're in trouble, but we're hoping to keep people out of the hospital. The next question is, what would be a normal treatment plan for telemedicine for a patient with sickle cell? It's very customized. The usual thing is to review and discuss their status and discuss their pain control and discuss their vaccine status, whether they've got pneumovax, whether they're going to get their influenza vaccine. Now we're talking about COVID vaccines. So this would be a customized thing, and then referral to other providers to talk about ophthalmology exam, GI provider for people with liver dysfunction, nephrologist. So kind of being, in a way, the quarterback would be the treatment plan. Also, focus on pain control. Now, as a hematology provider, we're able to provide some pain medications. So I can prescribe pain medications. I order pain medicine for the patient to pick up in their pharmacy, and we give them a plan for them to try to manage their acute pain with pain medications. Any sickle cell patient who has chronic pain that requires frequent pain medications or routine pain medications ought to see a pain specialist. So we're advising patients to do that, and we're really, more than anything, trying to help patients keep an organized strategy and framework for how they're going to manage their pain and how they're going to try to stay out of the hospital. So that's the way we're dealing with. We're trying to make a treatment plan for sickle cell disease, but above all else, really, it's a lot of education, just explaining to them what's going on with them and why they're suffering so much. Whether or not it makes sense for them to get blood transfusions and try to organize the transfusion strategy if that's going to happen. So lots of discussion about that, but I think you make the point, Ed, that, and you're right, that there's not a single strategy that works for everybody. And then you also asked me, thank you, you also asked me what patient information is required for telemedicine visit. I need to see the patient and talk to them about their history, and I need to know their lab testing results. And it's a lot of a review of what's going on with them. It's really more than anything about the history. But ideally, having other healthcare provider records, hospital records, would be helpful for sickle cell patients. Now, Rena asks, can remote patient monitoring be used to help sickle cell patients? If so, what type of monitoring? For hematology, the way I view it, we're doing remote patient monitoring by having lab testing, and we're sending people to local diagnostic labs like Quest and LabCorp. Now, I think remote patient monitoring should include home lab testing, but that hasn't been easy to accomplish up to this point. That would be the kind of thing I would expect to one day be able to do for sickle cell patient. Maybe they have a home blood draw device that they can stick on their skin and get a sample, and they can stick it on, so they don't need to go to a lab. Maybe this can somehow, hasn't been able to succeed yet, but somehow we get home CBC monitoring. And that doesn't always tell the whole story for sickle cell patient, but it's at least part of monitoring, part of their situation. Now, Tommy asks, why is sickle cell more prominent in African Americans, layman's terms? Thank you for that question. The easy answer is that these are genetic mutations that were felt to have originated in Africa and Asia and been selected for as a protective mutation against malaria. So that's the easy answer. I think it's probably more complicated than that in ways that we don't understand. And it could very well be that there are interactions amongst other genes that might be carried by African Americans that also enabled them to have sickle cell trait and to have carry sickle cell. But that's about all we have so far. It's the malaria story. And another question I have, thank you for that one, Tommy. I have, thanks for a brilliant webinar. After listening to doctor presentations, I feel pity for patients with sickle cell disease. How often do they need to run RBC transfusions and screening? Other side effects of the treatment? Okay, lots of questions. All right, sorry, I had to read all that. So the general idea is that we do what the patient needs. This is something that's a palliative condition, a palliative concept of taking care of people who have an incurable problem. They're suffering, their life is shortened, their life is impaired by this. So we're trying to figure out the risk-benefit profile for every thing that we do for a sickle cell patient. The risk-benefit profile for being in the hospital, for taking pain medicine, for getting a red cell transfusion, for taking antibiotics, for taking vaccines. In general, always when we do something, the benefit should outweigh the risk. That should be, or I should say, in general, we have to think that way. We have to hope and expect that the benefit outweighs the risk. Sometimes we don't appreciate the long-term risk, and we think that there's a short-term benefit that outweighs the risk, for example, getting blood transfusion. But we have a very strong need and push to really focus on providing treatments that hopefully have long-term benefit, possibly including transfusions for certain situations. So lots of questions there, but the general idea is that every patient's different with their risk-benefit profile. And the final question I have here is, Rena asks, have you seen an increase in rural providers reaching out to you for telehealth consultations in their sickle cell disease patients? You know, Rena, I'm hoping that we start to take care of all the rural sickle cell patients on telemedicine. And I will say that it has not taken off yet. This is something that's so needed and so obvious that we're going to make an impact this way. Seeing people on their phone, and even if they have other sickle cell doctors, we can see them on their phone in between their other appointments. Let alone, a lot of times sickle cell patients don't actually go to sickle cell doctors because there are so few of us, and they might be far from where they live, and they don't go to doctors if they don't feel sick. Maybe if they don't feel so sick, if they don't have a new event. So I should say that there's really a huge, well-known lack of sickle cell primary care, and also lack of sickle cell acute care, or adequate sickle cell acute care. All of that can be worked on as a telemedicine concept, especially in the rural areas. And I think there needs to be a big push to get sickle cell patients onto rural telemedicine hematology providers like my group. We haven't seen it yet. It hasn't taken off. I'm working on strategies to make everybody aware, including being here with you right now. So I'm going to continue that plan to raise awareness, but it hasn't taken off yet. Thank you for all those questions, and thank you to GPT for having me here today. It's a pleasure to be with you and to educate everybody about sickle cell disease. I hope that this generates even more thinking and discussion about sickle cell, and we're going to continue to make this a high priority for all of us to address and deal with, and hopefully solve as a telemedicine provider. And I look forward to working with GPT on this as well. Alrighty, have a good day.